And thanks for understanding. Sorry I missed my, my talk earlier. I'll be quick. I have no disclosures. So when we think about narrow aortic bifurcations, we generally define this as 20 millimeters or less. And it's probably a little bit more prevalent than when we typically think. When you look at this M2S database, it's pulled from 3 multi-center trials, and you can see 60% of these patients had actually had a distal aortic neck or distal aortic bifurcation less than 20, and then up to 30% were actually less than 16 millimeters. And so what's the problem? What are we looking at? What are we facing? It's basically a space issue, constraint within a certain narrow area where basically your endoprosthesis takes up a certain amount of area, and it can be potentially compressed and potentially kink, and then ultimately lose endograft patency as a result. I think there are two different types of narrow bifurcations. It's important at least to delineate it somewhat. You have that long, narrow aorta that can go for some length versus that napkin ring focal area of calcification that exists right at the aortic bifurcation. And I think they're a little bit different, and I'll talk about it a little bit later. Ultimately, this is what you're dealing with. You have an endoprosthetic with a certain size of device, and then you have a certain constrained area within the aortic bifurcation. When you look at, these are probably the 4 most commonly used devices. The Endurant has 2 13 millimeters limbs, so 26 millimeters. The Excluder and the Zenith are both 12, so 24. And then the smallest unibody of the AFX is 22, all of which are obviously greater than 20 millimeters in diameter. So typically, what a lot of people do is an aorta uni and a fem-fem bypass. That's the easiest way to get away with this. You have no constraint issues at that bifurcation as a result. But I think there are downsides of an aorta uni and a fem-fem. You have to get surgical groin exposure, so percutaneous is no longer an option. You're relying on that extra anatomic bypass for that contralateral limb. These bypasses can get infected, and they can thrombose, and you can lose patency as a result. Also, loss of native circulation and complete dependence on one limb, I think, can be a little bit dangerous. If that limb kinks or fails, then the entire lower body becomes ischemic as a result. So if you're going to preserve the native anatomy using a bifurcated device, one question is, does the device actually matter? So one of the possible solutions for a narrow aortic bifurcation is to use a unibody device. You eliminate that competition of the limb within that narrow space and then basically contour more similar to what that native anatomy is. And when you look at this benchtop model in a narrow distal aorta, you can see the difference between a modular bifurcated device versus that unibody bifurcated device. So bring your attention to the 12 millimeter benchtop model, and you can see there's more compression of those limbs as compared to that modular unibody setup. And here are 2 trials for using the Endologix unibody device. These are admittedly not designed to look specifically at narrow aortic bifurcations, but you can see that in one of the trials there were no limb occlusions, and in the other there were very few. Conversely, this was a paper that looked specifically at a modular bifurcated device, the Endurant device, looking at patients with a narrow aortic bifurcation, 20 millimeters or less. And when they compared the 2 groups, there was no difference in patency between the standard aortic bifurcation versus the narrow aortic bifurcation. And in this paper, they looked at the narrow aortic bifurcation again and bifurcated devices. They used 18 millimeters as the cutoff. And the bifurcated devices they used here were the Zenith, Anurex Excluder, and then those were all modular, and then including the Endologix. And you can see the primary patency out to 8 years was 96%. So really no issues, no limb occlusions, very few. Obviously these bifurcated devices were useful or could be used in these narrow spaces. Now when they did a subgroup analysis, they looked at narrow aortic bifurcations 14 millimeters or less, and this was not predictive of limb thrombosis or limb occlusion, so even smaller aortas were okay. And when they looked at the Endologix unibody graph, that was not protective against the narrow aortic bifurcation, again suggesting that modular devices were okay in this situation. But going back into this different type of anatomy, I think that your long narrow aorta versus your focal narrow aorta are 2 different things. I think in that long space, really putting a unibody device, in my opinion, is probably the better way to go. You have a long, narrow aorta. If you were to have 2 limbs competing through that space, I think there would be a higher risk of potential limb occlusion and limb thrombosis. And it's better to just contour something that's very similar and mimics the native anatomy, as opposed to that focal napkin ring space with that calcification, which can be overcome with adjunctive maneuvers. I think in that situation, it probably doesn't matter too much. So just some of the considerations to think about when you're treating these patients. This paper looked at predictive components of endograft limb stenosis, which was defined as a 50% stenosis. They looked at aortic bifurcation diameter, the sum of the limbs, and then the sum of the limb diameters over the aortic bifurcation diameter as a ratio, and then calcification. The one predictive component that could predict endograft limb stenosis was the ELD to ABD ratio of greater than 1.4. And that makes sense, right? The more, obviously, more limb or prosthetic you have in the smaller space would be more predictive of a problem. And when they had these situations, what they recommended was kissing balloon angioplasty and then subsequent adjunctive stenting when necessary. And certainly the idea of stenting is not something new. In this paper out of UCSF, they looked at their experience with the Zenith endograft, and in situations where they thought the limbs were compromised, including a narrow aortic bifurcation, they would put stents in. And they found that anybody who was stented had a 100% limb patency rate. So again, supporting that narrow aortic bifurcation with stents is a good way to go. And going back to this Endurin paper, when they looked at the narrow aortic group versus the standard aortic group, those patients in the narrow aortic group had a double rate, twice the rate of adjunctive stenting that helped create that patency and support those results. One last thing to think about is actually what are you doing here? You can see in this figure, you basically have kissing balloons, and then you have a narrow, usually calcified bifurcation. Ultimately, what you're doing is you're rupturing that space. So it's important to recognize that if you have a type 1 leak, you don't really want to go ahead and fracture that bifurcation, because you obviously could end up in a situation with significant bleeding or hemorrhage. So in conclusion, I told you I'd be quick. The narrow aortic bifurcation, I think, is defined by less than 20 millimeters. It's probably a little bit more prevalent than we would normally think. I think it's perfectly fine to do endografting and with a bifurcated device, and it should not be excluded as a result. Thank you.